Okay, I'm next. I'm the next speaker. So we're going to go through this quickly, but ultimately my goal here is to talk a little bit about the ABOM, the Angelman Syndrome Biomarker and Outcome Measure Consortium, and what that is. And I think we've mentioned a couple times that, for those of you who were in the talks yesterday, well, generally the talks yesterday on Thursday, we could put up my slides, please, are not meant for families and caregivers. They're very, very, very scientific talks. They're meant for regulators in the morning and industry and researchers, and then in the afternoon, they're really meant for researchers to talk together about how to better solve problems and challenges in their own research. So these talks for these 2 days, Friday and Saturday, are really meant for the community, for family and caregivers, to really break down the science to a level in which we can understand how that can have impact on your child or on your loved one. And so, but I did want to share a little bit about what happened yesterday, because it was pretty awesome, and it was an amazing, really amalgamation of people coming together to make a difference with pre-competitive sharing and ideas. We had the FDA there, the EMA was online as well. We were able to really hear from the people that are going to be making ultimate decisions for our children and give them and show them everything that we've done in the field as it relates to clinical trial design and developing the endpoints that are both meaningful and measurable. So I just wanted to walk you through what this is, because a lot of your money goes to this, and I think it's unfair if you don't understand it and if you don't know why. And so really what I wanted to talk about is what matters, what's meaningful, and what's measurable. And this is also going to relate to the patient-focused drug development meeting that Ryan's going to talk about this afternoon. And so I've already introduced myself, you know who I am. But what I want to focus on is my role, and I co-direct this Biomarker and Outcome Measure Consortium with Jennifer Panagoulias, who's in the audience. We co-direct this together, and she really is a regulatory phenomenon, and she really takes the lead of what the regulators are going to want to see and hear, and I take the lead of what is meaningful and what matters as a parent of a child living with Angelman. And we have the ASF there, who really can also play that role. We have other parents in the community that are part of it that also lay in and play that role, and so it really is the definition of patient-focused drug development. And so as the mother of Quincy, I think it's really easy for me to be able to do that. I gave you my disclosures earlier. So patient-focused drug development is what really matters, right? Why are we developing drugs? We're developing drugs to help patients. That is the ultimate goal. That is the absolute North Star to this organization, and it's the North Star to every parent or family member who is sitting in this room. And so we bring together these researchers and industry members and collaborators in order to help us reach that North Star. Well, this term, patient-focused drug development, or PFDD, was coined by people that actually often are not touching the patient at all. They try to talk to those of us who are. They try to understand what we understand and what we experience in our day-to-day lives and what our preferences are and what our lived experiences are, but they don't live it. And it's really easy to say something along the lines of, well, what parent would ever anesthetize their kid every 3 months for an ASO treatment, because that's invasive and that's challenging. Well, until you live a single day with a child with Angelman syndrome, if you can change the trajectory of their life by anesthesia every 2 months, every 3 months, every 4 months, every month, every 2 weeks, people might do that, because you don't know until you live it. You don't know until you experience change, right? And so what is that minimal change that would get you to a point in which you might be able to consider taking a risk on your child to put them in a clinical trial? Or you might consider changing their brain with a gene therapy to insert a gene that they don't currently have. Those are the things, those are the conversations that we have as a community and that we will continue to have. And it is our job to share that with those who are developing these drugs. And so when we talk about patient-focused drug development, the people that understand patient focus are you. And it's important you participate in all of the activities in order for us to be able to explain that to those who are doing much of the work. So the goal of this pre-competitive consortium is to create and identify drug development tools that will advance the regulatory science, so advance what the regulators who approve drugs and approve trials will actually understand about Angelman syndrome, to be able to make the measurement if the risk is worth the benefit. And that's really what's so, so important. And that's what we're here to do. So the purpose is to create this pre-competitive space. We invite people from every walk of life in the ecosystem of drug development, including basic researchers, clinicians, industry members, parents and caregivers, regulators. We put them all in the same room and it's totally pre-competitive. So what we learn in that room, everybody shares. There's not silos of proprietary ownership. Everybody shares. And that's why when we started this consortium, we wanted to be sure that we put it in a way in which there are no charters, there are no contracts, there's no CDAs, there's no non-disclosures. Anything we say at the table is to be shared. And so what happened by leading by example as patient advocacy groups between FAST and the Angelman Syndrome Foundation, coming together and having that mission and that real drive to share, all of our industry partners started sharing. And it really became this beautiful exchange of knowledge and information in order to be able to advance the field. Because if one group advances, the other group can then advance. And that really levels the playing field, and that's what's fair for our kids. And so that was really the goal, was to create this space that all stakeholders can come to the table, and we can really understand what is meaningful for change for our children and for our families. And then we need to highlight in those areas, how are we going to measure that change? We need to engage with regulators and ensure our efforts are aligned. We may have a really great idea on how we think we can measure something, and then we bring it to the regulators and they're like, there are so many flaws with that idea, there's no way you can do that. And so we wanted to be sure that we were aligned with those who understand the regulatory science of this, to be sure we're not flawed in our thinking and in our spending, because it's not inexpensive to advance these different measurements. We wanted to develop tools and novel tools, new tools, in order to measure Angelman syndrome symptoms and change over time, if those didn't already exist out in the field. And so we needed to think about, what are they doing in the natural history study? Do these things exist in the field and we can use them as a fit for purpose for Angelman? None of these things were developed for Angelman syndrome. How do we validate it for Angelman? And if we can't, do we then make something new and novel that is appropriate for Angelman syndrome, which is very expensive and takes a very, very long time. And we want to make sure we're using rigor as we advance these tools and doing it in the right way that's appropriate for the regulators, and then share these learnings across everyone. Make sure that nobody has an unfair advantage and that everybody is learning what we're learning, and that they can each do true patient-focused drug development, because we are giving them the tools and the resources and the know-how and the lived experience to be able to do that. And because of that, we are very unique as a patient advocacy group, because most other rare diseases don't have this type of forum to be able to do that. Our goal is that we need to ensure that drugs are approved because they actually work. We want drugs to be approved because they improve our children's lives. And if they don't, they need to be culled. We don't need to be advancing drugs that don't work, that are very expensive. We need to be advancing drugs that transform our children's lives in a very, very meaningful way. And those meaningful ways are different based on the family and the child, and we have to recognize that. So the mission is to be able to establish a framework for in order to help design clinical trials, make the endpoints and biomarkers available for all, particularly any sponsor in any area of development, whether it's a downstream target, whether it's an upstream target, if it's a gene therapy, if it's an ASO, if it's CRISPR. We want to make sure we're developing these tools for all to use, regardless of the mechanism of action of their drug. And the goal is to make sure we benefit all patients globally, patients of all ages, and patients of all genotypes. And this is a hard task for us to do. And so, like I showed you earlier, our pillar 4, the efforts to support clinical trial readiness for innovative therapies. Well, the ABOM is right here at the bottom, and I showed you this earlier. So let's focus on the ABOM a little bit. And I went over this slide, so I'm not going to talk too much about this, but basically from where we started when we established this pre-competitive consortium, and if I go back to this pre-competitive consortium in 2016, a lot of the support for this consortium was an incredible and unbelievably generous gift from one of our community members whose family heard our vision, our roadmap to a cure. And they understood it's not only developing the drugs, but it's actually also developing the tools. And they understood the value of that. And they made a large donation, which really accelerated our drug development pipeline. I talk about this as our second inflection point, I think, as a community. Well, the first is Art Baudet, so we'll talk about that as number one. He's our number one inflection point. Number 2 was the Fast Fire team, as far as I can see it, where they really put all their efforts in de-siloed research and really advanced programs in a really translational way. Of course, there were a lot of tools that were developed well before that had incredible impact. But for us, that inflection point was in 2012 with the FIRE team, which was an incredible donation from one of our other family members who's actually in the audience, and I won't embarrass anybody because they like to stay anonymous, but they know who I'm talking about. And then after that, it was the second inflection point, which was this huge infusion of funds by another family member. Again, he likes to stay anonymous, him and his family. I will not acknowledge who they are, but you probably all know who it is. He's sitting in the room somewhere over there. His name happens to be Julian, but I won't, you can use your best judgment if you want to talk to him about it. But his family made an incredible infusion of funds, and it really got this started. And it allowed us to say, you know what? We're going to put $1 million into this. We're going to put money in and advance these different endpoints quickly. And we're not going to do this in piecemeal. We're not going to do this piece by piece. And we brought on Terry Jo Bichelle, who's over there, to lead this effort, right? I didn't know how to lead this effort. And we were trying to develop drugs, and we were really deep in the science of the early stages of preclinical work. And Terry Jo was so passionate about endpoints and biomarkers, as she still is. And so she took this on while she was in her PhD, and she took on leading this initiative. And ultimately, what that was this pre-competitive consortium, the ASF, FAST, clinicians, industry, and we had 25 people at the table, and it felt enormous. And we were so proud of ourselves. Do you remember, Terry Jo? We were so proud. She created this real nice room of people. And here we are in 2024. There were over 300 people in attendance yesterday. We had FDA and EMA in attendance yesterday. And we had over 16 or 17 talks just on endpoints and biomarkers. We have come so far in such a short period of time because of this infusion of effort and funds and this pre-collaborative spirit with the Angelman Syndrome Foundation and FAST leading the way, which has been really, really exciting to watch. And so we already talked about the symptoms of Angelman, but this is what matters. This is what we have to measure. This is what we have to tell the story of these symptoms. How important are they? Let's make a hierarchy of these symptoms, and let's figure out how we can measure change in these symptoms. And it's not only to the patients, but it's also to their families. And that's incredibly, incredibly important. And so the first thing that we did, and this was led by Roche as well as Terry Jo Bichelle through the ABOM, was to develop this disease concept model. And what that means is that we needed to interview 25 caregivers, as well as I think it was 5 clinicians, and we wanted to understand what symptoms of Angelman syndrome in a hierarchy were most important to see change over time. And while we were waiting for that, because 25 people to be interviewed and write a paper about it actually took 3.5 years. Which this is unfortunately the rate at which things move. But we said, you know what, we could do better than that. Let's get an answer really quickly, and let's see if that corroborates just a survey. Let's go to Facebook. Let's do a survey with our families who are so willing to participate. And we did a survey of 322 caregivers or 332 caregivers on Facebook, and just said, rate the symptoms that are most meaningful and important to you that you would like to see change with a therapy. And overwhelming was communication and cognition. People want their children to understand, to express, and to function, and to be part of the community, to be part of the world that they live in, to have relationships in which there can be an exchange of receptive and expressive language and their cognition in order to be able to support their function in this world. That's what people wanted. That's what they wanted more than anything. And of course, seizures were close behind. Gait, daily life skills, independence, and activities of daily living. Those were all close behind. And it turns out the disease concept model completely corroborated with this survey that took 1 week to perform with 332 caregivers. 3 years later, we have a nice, beautiful paper that we can reference in all of our regulatory filings that support this survey. And we're going to do it again in front of the FDA in January, which I hope you'll all participate in. So along the same lines, well before this happened, in 2006, the team at Boston Children's Hospital and Rady Children's, they dug deep and they said, we need to understand the natural history of this disease. It's been 18 years of collecting endpoints. And those of you who participate in the natural history study, which Anjali Sadhwani will talk about later, really understand what the value of everything you've done, all those trips you've made to Boston or to San Diego or to North Carolina or even to Ontario in Canada. You guys have participated and contributed this. This work has been crucial to drug development for Angelman syndrome. And I'm going to let Anjali talk about that and really thank you from the bottom of her heart, but I want to thank you from the bottom of mine. We couldn't develop clinical trial design in a way that is so strong compared to other rare diseases if you all didn't participate year after year after year. And so you all deserve a round of applause. There are so few rare diseases that have natural history studies of more than 100 people. We have over 600 people. Globally, most of them are in the United States and North America, over 600 people, over 18 years. That is unheard of. And so the fact that we have that has really allowed us to be the low-hanging fruit for many of the pharmaceutical companies as well. And so we're going to hear a lot of data tomorrow. This is just public data that was shared by 2 of the pharmaceutical companies over the last 9 months or so. And they're going to update you tomorrow on new data, and they're going to really dive into this a little bit more. But the only thing I wanted to show you here is how they can use natural history study comparisons in order to show if there's any possibility that we believe that their drug might be having a treatment effect. And so what you can see in these slides is that you can see on the top, the black is the natural history change over time, and the red is the drug change over time. On the bottom, what you can see is that slope going up is the drug change over time, where that flat slope to the right of each of those red slopes is the natural history change over time. You can see that they corroborate, they're totally different. The drug companies are showing very similar impact in terms of these types of measures on these scales. But what it tells us is that the natural history data is so valuable. And now we have to talk about that's ways that we measure it. We brought all of these tools that we were working on in the natural history study to the FDA in 2018 through a patient-focused drug development meeting. We brought 5 caregivers and their children, and most of you were actually in the room, and you went and spoke to the FDA. And the FDA asked you, what would be the most meaningful area of change for you if your child got a treatment? And everybody said the same thing. Cognition and communication. Everyone said the same thing. Somebody said, well, I also want my child to walk safely and not fall. Someone also said, I'd love if my child could have less seizures because their child was impacted by more seizures. But they all really corroborated the same story that our survey showed and that publication showed. Cognition, communication were so overwhelmingly important to these families. And so this was really important. And because of that, that's how the ORCA was born. The ORCA is an endpoint that the FDA asked us to create in order to be able to measure communication abilities in individuals living with Angelman syndrome. The ORCA stands for the Observer-Reported Communication Abilities Scale, or measure, and this basically measures our children's ability to have receptive understanding, expressive language using AAC, gestures, signs, words, sounds, word approximations, all the ways our kids communicate. These scales that have been around for the last 2 decades only measure change by words. And if your kid can change by using their AAC device and can go from knowing 1 symbol to over 100 symbols, that's hugely meaningful. But how are we going to measure that on a scale that doesn't use AAC as part of the scale? So the FDA asked us to create that measure and let it be parent-reported because it's the parent's perspective of their child's communication abilities that matter. And so we leveraged the work of Dr. Bryce Reeve at Duke University. We developed the ORCA, which was designed just for Angelman syndrome, and subsequently the FDA gave them $2.5 million to advance it for 14 other neurodevelopmental disorders. And so an example of how we're leading the way in Angelman syndrome for all of these other disorders as well, and we're allowing ourselves to create the playbook for others, which is so incredibly important. And so for the ABOM, it was what's out there for these measures that we talked about, for these domains that we talked about. What actually measures our kids, and how do we design these clinical trials? So we created this hierarchy, and we funneled it down to best clinical trial design. And that's why the endpoints being used on all of these studies are the same, because we've narrowed down what is measurable and meaningful to families and allowed all of the companies to utilize the same measures. So we can truly compare effect head-to-head over time. And so these are all the things we've done, and this is all the money we've invested in that. And that's because it's so, so, so important. The natural history study is so robust, and Anjali is going to talk about this, but this has guided us in order to be able to utilize the old measures and add new measures over time and understand longitudinal change. And all of this work that you put in year after year is not being taken for granted. Ryan's going to talk to us about why this matters to the FDA and how we need you involved in January to be able to talk to the FDA about this. Because what you tell them of what would be the minimal meaningful change for you in a drug trial is the difference between a drug being approved and not being approved. And we only want drugs approved that work, but we don't want drugs to not get approved because they don't work enough in the eyes of somebody who doesn't live with Angelman syndrome, but they work robustly in the eyes of those of us who do. That would be a travesty that we can't let happen. And so that's very, very important to get yourself involved. Here's the website to really be heard. These are those talks we had yesterday. It's crazy. A lot of talks, and here are the take-homes. The global regulatory engagement in the US and Europe was present. For the first time, we had both of them present. We've had the FDA for a couple years. This is the first time we got the EMA to attend virtually. Industry and advocacy alignment was very clear. It was palpable in the room that we're all aligned on what we're looking at, and we all believe in the same things, and we're all working together to figure out how to measure it. And we're advancing the field hugely, not only for Angelman syndrome, but for other rare genetic conditions, neurodevelopmental disorders. And the reminder was very much clear to the FDA that patients are waiting. And they understood that, and Peter Marks, the director of CBER, the Center for Biologics of the FDA, he even repeated these words, and he said, "I heard the talk before mine." He was the keynote speaker yesterday, and said, "It is clear to us that patients are waiting." And that is the message we needed to send, and we need to send the message on how we're going to measure that. And so the highlights are Peter Marks talked about accelerated drug development. There was a parent panel on minimal, meaningful differences in clinical trial assessments. What would be most meaningful to parents? It was so clear toileting is so meaningful, but it's not something that maybe the FDA would think about. Activities of daily living and independence, independently feeding and not making a mess everywhere, having your kids sit around dinner with you, and being able to feed themselves while you also feed yourself. And you can have an engaged conversation with your family at dinner instead of a transactional experience where you're feeding your kid and cleaning up their mess while the rest of your family is having a conversation and eating, and while they clean up the table, you're eating alone. That's not what we want for families, and that's not what families want. That was very clear. The ORCA is redefining the communication abilities in Angelman syndrome, and it's looking like it can truly measure our kids, and we're not hitting a ceiling or a floor, they're being measured. The FDA's perspective on sleep as an endpoint, because they understand how important improvement in sleep is as a family. EEG and MRI as a biomarker to be able to look at change on the delta power. As we showed you in the mice can change their delta power. We're going to show you tomorrow humans can change their delta power. Roche is going to have a really nice talk talking a little bit about their EEG work. And so MRI can change as a biomarker. CSF fluid, we can detect new proteins in the CSF. Maybe that can be a biomarker to ensure that we're measuring change from a biochemical perspective and from a symptomology perspective. It's so, so incredibly important because the quality of life in Angelman syndrome really matters, both to parents and to the patients. And so overall, I just want to thank you. This is what the ABOM does. This is why we're here. But your engagement, your involvement is crucial to allow us to do this very important work, to take those beautiful drugs we talked about this morning and be able to ensure that we can get them approved for patients. Thank you.